Now I'm going to introduce our next speaker. Teresa Lowry Lehnen is a qualified specialist practitioner in general practice nursing. She's a registered nurse prescriber and a teacher of science, health science and nursing studies. She has a PhD, published a number of books and medical journal articles, and is a registered teacher with the Teaching Council of Ireland. She has 38 years experience in clinical nursing practice, combining her practice with 18 years in educational teaching and lecturing roles. She is currently employed as an associate lecturer and full-time nurse at the Medical Centre in the Institute of Technology, Carlow. And she also, part of her career, she spent in telephone triage. So she's now going to give a presentation on the menopause.
Hello, my name is Teresa Lowry Lehnen. I am a general practice nurse and a member of the National Executive Committee of the Irish General Practice Nurses Educational Association, formerly the IPNA, who represent almost 1,000 general practice nurses and the educational and professional development of general practice nurses in Ireland. As a former triage nurse and employee at CareDoc from 2008 until 2015, I am aware of the outstanding and very valuable work you do in primary care every day and was delighted to be asked to present at the INMO Telephone Triage Nursing Section webinar today. This presentation is on the topic of menopause. The menopause can be defined as the last day of a woman's final menstrual period. The World Health Organization defines natural menopause as at least 12 consecutive months of amenorrhea, not due to physiological and pathological causes. The term menopause is used to describe the transition phase during which a woman moves from the fertile to the post-fertile stage of her life. However, this phase should be referred to as perimenopause or climacteric. Menstrual periods usually become less frequent over months or years before they finally end. The frequency and severity of menstrual periods during this transition can be irregular and vary. They may become light, very heavy, occur every 2 or 3 weeks, not occur for months at a time, and sometimes they can just stop suddenly. This chart shows the changes in estrogen levels and the estrogen and progesterone levels, how they rise and fall throughout the lifespan of a female. The menopause is a natural part of aging that usually occurs between 45 and 55 years of age as estrogen levels decline. Ovarian function declines with age. The onset of menopause features decreasing production in estriadiol and increasing levels of follicle-stimulating hormone. Symptoms usually last around 4 years after the last menstrual period, although some women experience symptoms for longer. The average age to reach menopause is 51 or 52 years of age. When it occurs under the age of 45 years, it is called premature menopause. It is estimated that premature menopause affects 1% of women under the age of 40 and 0.1% of women under the age of 30. Sometimes menopause can be induced through invasive treatments, which can include surgery such as oophorectomy, some breast cancer treatments, chemotherapy and radiotherapy, and underlying conditions such as Addison's disease. The menopause transition is experienced by 1.5 million women globally each year and involves vasomotor symptoms, vaginal dryness, decreased libido, insomnia, fatigue, mood changes, lack of concentration, increased urinary tract infections, reduced bone and muscle mass, and joint pain. Vasomotor symptoms affect most women during the menopausal transition. Severity, frequency, and duration varies. Hot flushes are reported by up to 85% of menopausal women. Hot flushes and night sweats are present in as many as 55% of women even before the onset of menstrual irregularity that defines the entry into the menopausal transition. Incidence and severity increases as women traverse the menopause, peaking in the late transition and tapering off over a number of years. The exact cause of hot flushes and night sweats is uncertain. It is thought to be due to the resetting and narrowing of the thermoregulatory system in association with fluctuations in or loss of estrogen. The average duration of hot flushes is 5.2 years, although symptoms of lesser intensity can present for longer. Approximately 25% of women continue to have hot flushes for up to 5 years or more after the menopause. A meta-analysis of 35,445 women taken from 10 different studies confirmed a 4-year duration of hot flushes, with the most problematic symptoms beginning 1 year before the final menstrual period and declining thereafter. Multiple population and community-based studies confirm 27% to 60% of women report moderate to severe symptoms of vaginal dryness or dyspareunia. In addition to vaginal atrophy, narrowing and shortening of the vagina, uterine prolapse can also occur, leading to high rates of dyspareunia. The urinary tract contains estrogen receptors in the urethra and bladder, and as the loss of estrogen becomes evident, women may experience increased urinary tract infections. Unlike vasomotor symptoms, vulvovaginal atrophy does not improve over time without treatment. The menopause increases the risk of developing osteoporosis due to the lower levels of estrogen. During menopausal transition, the drop in estrogen levels leads to more bone resorption than formation, resulting in bone loss. Osteoporosis is the most prevalent disease in menopausal women and is strongly associated with a low quality of life. The prevalence of osteoporosis and related fractures are higher in postmenopausal women than in older men, since estrogen plays a key role in maintaining bone health. The fracture risk is higher in women than in men, and the lifetime risk of fractures for a 60-year-old woman is close to 44%, nearly double the risk for a man of the same age, which is 25%. Low estrogen levels are the main cause of postmenopausal osteoporosis. HRT is often considered as a first-line choice for prevention of osteoporosis, and its effectiveness has been demonstrated by multiple studies. HRT is recommended for women who are less than 60 years of age and are less than 10 years postmenopausal. For those over the age of 60 years and or greater than 10 years postmenopausal, HRT is not recommended and other options should be considered. There is no definitive test to diagnose the menopause, although measuring the level of follicle-stimulating hormone in the blood can help confirm a diagnosis. High levels of FSH alone is not enough to make a diagnosis. A diagnosis can usually be confirmed in general practice by considering the woman's age, whether or not she is still having periods, asking questions about symptoms through a thorough history, which should also inquire about incontinence and sexual dysfunction. Blood pressure and BMI measurement and relevant blood tests should be included in the consultation, and optimal breast and pelvic examination, cervical smear test, and mammography organised if required. The opportunity should also be taken to counsel and advise the woman with regard to general health screening, diet and exercise, bone health, and contraception if required. Only 1 in 10 women seek medical advice when going through the menopause, and many do not require any treatment. If menopausal symptoms are discomforting, there are treatments that can help. Treatment options include hormone replacement therapy, tibolone, which is similar to HRT, clonidine, vaginal lubricants, and antidepressants. The type of treatments recommended depend on the woman's symptoms, medical history, the risks or side effects associated with the various treatments, and the woman's own preferences. HRT and tibolone do not provide contraceptive protection, and although fertility decreases during the menopause, it may still be possible to conceive. Continued use of contraception is recommended for 1 year after the woman's final period if over the age of 50, and for 2 years after the last period if under the age of 50. Hormone replacement therapy involves taking female hormones to restore the decline in the body's levels during menopause. The NICE final guidelines of 2015 state that HRT is effective and should be offered to women after discussing the risks and benefits. There are two main types of HRT. Combined HRT, which contains estrogen and progesterone, can be taken by women who still have a womb, and estrogen-only HRT is available for women who have had a hysterectomy. HRT is available in oral form as tablets or as transdermal patches, gels, intravaginal pessary or rings, nasal sprays, and implants. HRT is very effective at relieving menopausal symptoms, especially hot flushes and night sweats, but it is associated with a number of side effects, including breast tenderness, headaches, and vaginal bleeding, and is also associated with an increased risk of blood clots and breast cancer in some women. HRT has been the subject of much controversy and received negative press over the past 2 decades, leaving many women and some clinicians concerned about its use. Concerns about HRT are based on 3 main studies which took place between 1998 and 2003. These 3 studies were the Heart Estrogen-Progestin Replacement Study of 1998 in the USA, the Women's Health Initiative Study of 2002 in the USA, and the Million Women Study of 2003 in the United Kingdom. Negative reports about HRT are largely due to the Women's Health Initiative Study of 2002, which has since been shown to be flawed. The WHI study mainly included older women that were given types of HRT that are no longer prescribed today. Women included in the study were aged from 50 to 79, with the average age being 63 years, with only 3.5% of participants in the 50 to 54-year age group. Women with severe symptoms were excluded, and women with previous serious CVD were included in the study. When WHI published the study, they documented that a small increased RR in breast CA, 1.26, was observed, which did not reach statistical significance. However, the following year, a JAMA editorial reported that the WHI study had demonstrated that breast cancer rates were markedly increased in the HRT group. This continues to lead to controversy and negative press about HRT today. Most experts agree that if HRT is used on a short-term basis for no more than 5 years in women under the age of 60, the benefits outweigh the risks. HRT can reduce the risk of developing osteoporosis as well as cancer of the colon and rectum. HRT does not increase the risk of heart disease in women under 60. Current data shows that HRT use before the age of 50 years carries no additional risk of breast cancer, while its use between the ages of 50 to 54 years is linked to a small additional risk. HRT use in women over 50 is linked to increased breast cancer risk, with data showing 30 cases per 10,000 in women who never used it, compared to 38 cases per 10,000 in women who did use it. Women with known CVD, angina, and MI should avoid HRT, as should women over 10 years post the menopause. Data also shows that women less than 10 years from the menopause or under 60 years of age may derive some cardioprotection from HRT use, but further studies need to be carried out to confirm this. Observational data also suggests that transdermal HRT may be less thrombogenic than oral preparations. In the first 2 years after commencing oral HRT, the risk of developing a DVT is slightly raised. HRT should be avoided in women with a current or recent past history of DVT, and caution taken with women who had VTE around pregnancy or while on COCP. Women with a strong family history of or multiple risk factors for DVD would benefit from hematological review before treatment and may be safer to use transdermal products. Women taking HRT must be regularly reviewed and monitored in general practice. A follow-up review should take place 3 months after commencing HRT and at least once a year after that. Regular reviews help ensure that symptoms are under control, side effects are checked for, and weight and blood pressure are monitored. The type and effectiveness of HRT used will be reviewed and changes made if necessary, and discussion will also take place about when and how the treatment will eventually be discontinued. Alternative therapies for hot flushes and sweats include alpha agonists such as clonidine HCl 50 to 75 micrograms twice a day. Side effects can include insomnia, dry mouth, and drowsiness. Other alternative therapies for hot flushes and sweats include COC, the combined oral TD-TV contraception, and selective serotonin reuptake inhibitors and gabapentin. NICE guidelines suggest that 900 milligrams daily of gabapentin has been shown to reduce vasomotor symptoms by approximately 50%. Gabapentin may be of use in women with breast cancer. CBT has also been found to be beneficial over placebo in several aspects of perimenopausal management, including VMS relief. Mindful meditation practice is also recommended by NICE to help with low mood and anxiety. Estrogen applied as a pessary, cream, or vaginal ring directly into the vagina can be prescribed for vaginal pain, itch, or dryness. This can be safely used alongside HRT, but may need to be used indefinitely, as symptoms are likely to return when treatment is stopped. Over-the-counter vaginal moisturizers or lubricants can be used in addition to or instead of vaginal estrogen. Some women experience mood swings, low mood, and anxiety during the menopause. Self-help measures such as rest, taking regular exercise, and relaxation activities may be beneficial. Selective serotonin reuptake inhibitors may be used for the treatment of low mood or depression associated with menopause. Loss of libido is a common symptom during the menopause. HRT can help, but if not effective, a testosterone supplement may be considered. Testosterone, the male sex hormone, can help restore sex drive. While it is not currently licensed for use in women, it can be prescribed by a doctor. Possible side effects of testosterone therapy can include acne and facial hair. A healthy, well-balanced diet, including oily fish, low GI fruits and vegetables, whole grain, soya and legumes should be encouraged. Excess red meat and simple sugars should be avoided. Vitamin D and calcium is important for bone health, and an intake of at least 10 milligrams per day of vitamin D as a supplement should be considered, and calcium 700 to 1,200 milligrams daily, preferably taken via the diet. Regular physical activity is important for overall physical and psychological health. It improves the cardiovascular system and helps decrease LDLs and increase HDLs. Physical activity has a beneficial effect on bone and muscle mass and can help reduce the risk of falling by improving strength, flexibility, and balance. Taking HRT can help prevent osteoporosis, although this effect does not last once treatment is stopped. Regular weight bearing and resistance exercises and a diet rich in calcium and vitamin D, remembering that sunlight is the best source of vitamin D production in the body, helps to strengthen bones. Stopping smoking and cutting down on alcohol if applicable is also good for maintaining general and good bone health. Complementary and alternative therapies such as herbal remedies and bioidentical hormones are generally not recommended for menopause symptoms, as it is unclear how safe or effective they are, and some may interact with other medications and cause side effects. With increased life expectancy, women now spend at least a third of their lives postmenopausal. CSO statistics show that almost 333,000 women in Ireland are potentially perimenopausal at any one time, and 8 out of 10 women experience symptoms leading up to menopause. Once a taboo subject and rarely acknowledged in Irish society, it is reassuring to see the range of care and menopausal treatments available in general practice and the growth of dedicated menopausal clinics nationwide to help women manage their symptoms through the transition phase of what can be a very difficult time in their lives. Let's now consider the role of the general practice nurse. We provide screening, assessment, treatment and management of symptoms of women with menopause. We provide a holistic person-centered approach, ongoing support and education for women. We establish a therapeutic relationship with the patient, assess their understanding of their condition, establish goals and expectations for successful management of the condition, and evaluate the physical, emotional, and psychological effects of the menopause on the woman's well-being. We are involved in communication, advocacy, and counselling. We provide assessment, monitoring, audit, and evaluation of the therapeutic regime on a patient, and this is a continuous process. Many nurses can now also prescribe medications, perform diagnostic examinations, and prescribe other types of medical treatments, either independently or in conjunction with a doctor. We are leading the way in quality improvement initiatives and research, and we implement person-centered care, monitoring and evaluation of symptoms, outcomes, and responses to therapy. This is a list of the references that were used in the production of this presentation. I hope you have enjoyed this presentation on the menopause. My name is Teresa Lowry Lehnen, and it was a pleasure to speak to you today. Thank you very much for watching and listening.